When you step into an intensive care unit, it's kind of wild because all the expectations you have about modern medicine they just evaporate.
Right. Yeah, it's a completely different world.
Because usually, when we talk about a medical diagnosis, there's this comforting expectation of precision, Like you break your arm,
Yeah.
the x-ray shows that jagged white line, and the doctor just points at the film and says, well, there it is.
Exactly. It's very binary.
Yeah, binary. Broken or not broken. It's clean.
I mean, we really crave that certainty, right? We want our biology to be as legible as like an engineering schematic.
But the ICU totally doesn't care about our comfort.
Yeah.
You walk into this world of, multi-system organ failure, of septic shock, of these undifferentiated crashing patients. And that x-ray machine is just utterly useless.
Completely useless in that context, yeah.
You aren't looking for a broken bone. You're looking at a diagnostic landscape that is entirely murky. I mean, the stakes are absolute, the data is just overwhelming, and the margin for error is, well, essentially zero.
It is the absolute definition of diagnostic muddy waters. And navigating those waters, synthesizing all that chaos in real time is exactly what separates, a capable physician from a true master of critical care.
Which brings us to our mission today. We're opening up the master blueprint for how experts navigate this exact chaos. We're diving deep into the excerpts from the Critical Care Board exam Pearls for the 2026 certification.
Yes.
And sure, on the surface, this is just a study guide for doctors.
Yeah.
But if you read between the lines, it is an absolute masterclass in human pathophysiology.
Oh, without a doubt.
It's the playbook for how the most highly trained medical minds make, literal life or death decisions when a body's systems are in total freefall.
Right. And to really grasp the weight of this, we need to look at how the exam itself is actually built. Because the creators of this 2026 certification, they have very heavy-handedly prioritized life-threatening pathologies and the real-world application of landmark clinical trials.
They're sending a message.
They really are. They are telling candidates, in no uncertain terms, what matters most when those alarms are going off.
And we've custom-tailored this deep dive specifically for you, the listener. So whether you are actively prepping for your medical boards, or maybe you're a student trying to wrap your head around just the sheer complexity of ICU physiology, or even if you're just insanely curious about how the human body operates at the absolute extremes of survival, this is for you.
Absolutely.
So let's look at those priorities. Like, where does the exam actually place its focus?
Well, the exam weights are essentially a hierarchy of mortality.
Okay, wow.
Yeah, so pulmonary disease, which is everything related to the lungs, gas exchange, ventilators, is the massive one. That takes up a full 20% of the entire exam.
20%, just on lungs.
Right. And right behind it is cardiovascular at 17.5%.
Makes sense.
Then you have renal, endocrine, and metabolic disorders grouped at 15%. Infectious disease comes in at 12%, and neurology sits at 9.5%.
So it's basically a timeline of how quickly a system failure will kill you. Like no air, then no blood flow, no filters, no brain.
Precisely. I mean, you can survive a kidney injury for days, right? But you will die from a lack of oxygen in minutes.
Yeah, that's a grim but helpful way to think about it.
But what's even more fascinating than what is tested is how it's tested. The cognitive demands are incredibly rigorous. 50% of the test focuses entirely on treatment and care decisions, and 40% is on diagnosis.
So 90% of the score is just about action and identification right in the moment.
Exactly. It is emphatically not about rote memorization of textbooks. It's about synthesizing these wildly fluctuating data points in undifferentiated, really messy scenarios.
And before we get into the heavy physiology, there's this brilliant psychological pearl buried right in the introduction of the source material.
Oh, this is a great one.
It's so good. It's pitched as a test-taking tip, but honestly, it is a life hack for any high-stakes cognitive task you might face. The authors explicitly warn these brilliant doctors not to study or research topics during their scheduled exam breaks.
Yeah, they're pointing to a psychological phenomenon called retroactive inhibition.
Okay, let's unpack this because it blew my mind.
Yeah.
If you are taking a grueling, 8-hour exam and you get a 10-minute break, the instinct is to frantically check your notes, right?
Oh, yeah, always.
To cram in one last fact. But why does the medical board explicitly tell you that doing that will actually destroy your score?
Because of how human memory consolidation works. I mean, think of your working memory like your brain's RAM as a delicate sorting facility.
Okay.
During the exam, you are pulling deeply consolidated foundational knowledge from your long-term storage, you're applying it to a really complex problem, and then putting it back.
Right.
If you take a break and suddenly try to jam brand new outer context information into that sorting facility, it physically disrupts the neural pathways you were just relying on.
It essentially overwrites the hard drive
Yeah.
and just scrambles your recall.
Exactly. The new panicked information interferes with the retrieval of the old stable information. Plus, it massively spikes your cortisol, which further paralyzes your prefrontal cortex.
That's wild.
It really is. It's a perfect microcosm of critical care itself, honestly. Cognitive overload is a very real, very physical danger, both for the test taker in a cubicle and for the physician standing at the bedside.
Yeah.
You have to trust your foundational knowledge and just let the system rest when it can.
So for you listening, whether you're facing a board exam or a massive corporate presentation or even a final, when you take a break, actually take the break. Stop trying to jam more data into the RAM.
Great advice.
But speaking of that foundational knowledge, we have to start at the absolute beginning of survival. The first thing that kills you. The breath of life. Pulmonary mechanics and the map of oxygen.
Yes, the big 20% chunk.
Exactly, because before we can even begin to talk about the heart pumping blood, we have to understand how oxygen gets into the blood in the first place. And surprisingly, that requires some incredibly elegant mathematics.
It does. And the reason we need math is because, well, in the ICU, you can't just look at a patient or even look at a chest x-ray and know what's happening at a microscopic level inside their alveoli.
Right, the alveoli being those millions of tiny balloon-like air sacs deep down in the lungs where the actual gas exchange happens.
Right. Oxygen has to cross the microscopic membrane of the alveolus into the bloodstream, but we can't stick a probe into a living person's alveolus to measure the oxygen in there. It's clinically impossible.
Sure.
We can easily draw blood from their wrist, like an arterial blood gas, to see how much oxygen made it into the artery. That's our little AO2.
Okay, little A for artery.
Exactly. But if a patient is suffocating, how do we know if the lung tissue itself is failing or if they just aren't breathing hard enough? We need to know how much oxygen actually made it into the lung spaces to begin with, the big AO2.
Which brings us to the alveolar gas equation. I mean, it's the cornerstone of pulmonary medicine. So how do we actually calculate this invisible number?
Well, we use the variables of the world around us plus the patient's own exhaust fumes. The equation to find the alveolar oxygen, the big AO2, starts with the atmospheric pressure minus the pressure of water vapor.
Right.
You multiply that result by the fraction of inspired oxygen, which is the FiO2. Then from that entire number, you subtract the patient's arterial carbon dioxide level divided by a constant called the respiratory quotient.
Okay, my eyes just crossed slightly, so let's translate that into actual human biology.
Yeah.
Atmospheric pressure at sea level is constant 760 millimeters of mercury. Why are we subtracting water vapor pressure, which the text says is 47?
Because the human body is a wet, warm environment, right?
Yeah.
When you breathe in dry room air, your nasal passages and your trachea instantly humidify it.
Oh, I see.
Yeah, and that water vapor takes up physical space in the gas mixture inside your lungs. It exerts a pressure of exactly 47 millimeters of mercury at normal body temperature. So the total pressure available for just oxygen and nitrogen is no longer 760, it's 760 minus 47.
That makes perfect sense.
Yeah.
And then we multiply that by the percentage of oxygen they are breathing, which is 21% on room air, or up to 100% if they're on a ventilator.
Exactly.
But it's this last part that I want to push back on a little bit. Subtracting the carbon dioxide divided by the respiratory quotient, which is generally 0.8. Why 0.8? Why not just 1? I always thought human breathing was like a perfect one-to-one swap. One molecule of oxygen in, one molecule of carbon dioxide out.
That is a very common misconception, actually. Biology is not perfectly symmetrical. The respiratory quotient represents the ratio of carbon dioxide your body produces to the oxygen it consumes.
Okay.
And the reason it's 0.8 and not 1.0 is because of the chemical structure of what we eat and burn for fuel. If you only ate pure carbohydrates, the ratio would be exactly 1.0. But we burn a mix, right? Carbs, proteins, and fats. Fats require much more oxygen to break down metabolically than the amount of CO2 they produce as waste. So on a standard human diet, we are always consuming slightly more oxygen than we are exhaling carbon dioxide, hence 0.8.
That is fascinating. So we do all this beautiful math to calculate exactly how much oxygen is sitting in the warehouse of the lungs, which leads us directly to the A gradient. Big A for alveoli, little a for artery. I love this
Like a
concept.
great tool.
Think of the A gradient like a shipping invoice. Big A is the inventory of oxygen that was successfully shipped to the warehouse, the lungs. Little a is what actually arrived at the final destination, the bloodstream.
That is the perfect analogy. You are comparing what was sent versus what was received and seeing if any inventory was lost in transit.
Right. The standard formula for a normal A gradient is your age divided by 4 plus 4. So if you're a healthy 24-year-old on room air, your gradient is 24 divided by 4, which is 6, plus 4 equals 10.
Correct.
A gradient of 10 millimeters of mercury. So if oxygen always gets lost in transit, it's just normal anatomical inefficiency. But clinically, in the ICU, why is this gradient the ultimate diagnostic weapon?
Because it tells you exactly where the failure is happening. Let's say a patient is brought into the ER. They are severely hypoxic, turning blue. Their oxygen saturation is in the 70s.
Bad situation.
Very bad. So you draw their blood, you do the math, and you calculate their A gradient. If the gradient is totally normal, say it's 10 or 15, what does that mean? It means the shipping process between the lung and the blood is working flawlessly. The lung tissue itself is perfectly healthy.
Wait, so if the lung is healthy, why are they turning blue?
Because they simply aren't breathing enough air into the warehouse to begin with. This is a pure ventilation problem, right? Maybe it's an opiate overdose suppressing the brainstem's drive to breathe. Or maybe it's a neuromuscular disease like ALS, where the diaphragm muscle is just too weak to pull air in. The treatment isn't to fix the lung, it's to fix the drive to breathe.
But if you calculate that gradient...
Right, if you calculate the A gradient, and it is massively widened, say it's 150 or 200, that tells you plenty of oxygen was shipped into the lung, but it is entirely failing to cross over into the blood.
Because the tissue is damaged.
Exactly. Now, you know the lung tissue itself is fundamentally broken. You are dealing with a diffusion defect, like pulmonary fibrosis, where the membrane is scarred thick. Or you have a massive shunt, where blood is bypassing the ventilated areas entirely, like in a severe pneumonia, where the alveoli are full of pus.
So the invoice doesn't match the delivery, which means the warehouse itself is destroyed. It's literal forensic accounting for respiration. I love that.
It really is.
But securing that oxygen brings up a totally mind-bending concept regarding the oxygen delivery equation. The equation is oxygen delivery, or DO2, equals the arterial oxygen content times the cardiac output times 10.
Yes.
Now, here's where I get confused. If a patient's lungs are failing and they are severely hypoxic, my instinct as a layman is just crank up the oxygen dial, right?
Yeah.
Just increase the pressure on the ventilator as high as it goes to force the air into their blood. Why wouldn't that be the right move?
What's fascinating here is the second-order physiological effect. This is the classic deadly ICU trap that the boards test relentlessly.
Okay, lay it on me.
So, yes, you have a dial on the ventilator called PEEP-positive end expiratory pressure. It acts like an invisible stent of air, constantly holding the lung sacs open.
Right.
And yes, if you crank that pressure way up, you will force open collapsed alveoli and push more oxygen across the membrane. If you look at the patient's arterial blood gas, the little AO2 will look fantastic.
So the oxygen content goes up. That sounds like a win.
It looks like a win on the monitor. But look at the anatomy. The lungs sit inside the rigid box of the chest cavity right next to the heart.
Yeah.
If you inflate the lungs with massive, unnatural amounts of continuous pressure, they physically expand and compress the heart. Specifically, they squish the right atrium and the vena cava, the major veins, returning blood to the heart.
And if you compress the veins?
Blood can't flow back into the heart effectively. Venous return plummets, and if the heart isn't filling with blood, it has nothing to pump out, so your cardiac output drops off a cliff.
Oh, wow. And going back to the delivery equation, oxygen delivery is a product of the oxygen content multiplied by the cardiac output.
Exactly. Let's say you doubled the oxygen in the blood by cranking the ventilator pressure.
Okay.
But because you squished the heart, you cut the cardiac output in half. Your net delivery of oxygen to the brain, the kidneys, and the liver is zero improvement.
Yeah.
In fact, you might paradoxically starve the tissues of oxygen and push the patient into multiple organ failure by obsessing over fixing a single number on a blood test.
So you successfully treat the monitor, but you kill the patient.
Precisely.
That is the razor's edge we are talking about. You have to constantly balance lung mechanics against cardiac function. Which brings us to the ultimate lung crisis, the disease where this balance is hardest to strike. ARDS, acute respiratory distress syndrome.
ARDS is the nightmare scenario for pulmonary mechanics. It is characterized by diffuse alveolar damage. Whether the trigger is a massive pneumonia or sepsis or severe trauma, the body's inflammatory response just goes haywire.
It's an overreaction.
Very much so. Cytokines flood the lungs, causing the capillaries to become wildly leaky. Protein-rich fluid pours into the delicate air spaces. It is a non-cardiogenic pulmonary edema, meaning the lungs are literally drowning in fluid, but not because the heart is backing up.
The board pearls mentioned the Berlin definition for diagnosing this. What exactly are the criteria?
The Berlin criteria are very strict. It requires acute onset within 7 days of a known clinical insult.
Okay.
It requires bilateral opacities on a chest x-ray, meaning instead of looking mostly black and clear, both lungs look entirely white and fluffy.
Like clouds.
Yeah. And crucially, you have to rule out simple congestive heart failure as the primary cause of that fluid.
And they grade the severity using the PF ratio. That's the arterial oxygen level, the P divided by the fraction of inspired oxygen, the F. It creates a standardized scale.
Yes. Mild ARDS is a ratio between 200 and 300, moderate is 100 to 200, and severe ARDS is a ratio of less than 100.
So when a patient hits that severe category, their lungs are incredibly stiff and fragile. How do we ventilate them without destroying what's left of the tissue? Because the source material highlights a landmark trial here called the ARMA trial, run by the ARDSnet group.
The ARMA trial is one of the most important studies in the history of critical care. It fundamentally completely revolutionized how we approach mechanical ventilation.
What were they doing before?
Before ARMA, the prevailing medical dogma was, well, the patient's lungs are sick, stiff, and collapsing. We need to push massive, deep breaths of air into them to force them open and keep the blood oxygenated.
Which honestly sounds completely logical.
It was entirely logical, and it was deeply harmful. They were using tidal volumes, which is the size of each breath, of around 12 milliliters per kilogram of the patient's predicted body weight.
That is a huge amount of air for a single breath.
It was far too much. What the ARMA trial proved conclusively was that these large volumes were causing horrific secondary damage to the lungs.
Like blowing up a balloon too much.
Exactly. We call it volutrauma, literally injuring the lung tissue by overdistending and physically tearing the alveoli, and barotrauma, which is injury from the sheer mechanical pressure. The trial established that to save the patient, we must use lung protective ventilation.
So what did they change?
They cut the tidal volume in half, down to 6 milliliters per kilogram. They proved that you have to intentionally give the patient smaller, shallower breaths to protect the physical architecture of the lung.
But wait, if you cut the air in half, their carbon dioxide levels are going to rise and their oxygen is going to look worse.
Yes. And that is a trade-off the trial taught us to accept. It's a strategy called permissive hypercapnia.
Permissive hypercapnia.
Right. You tolerate a slightly elevated carbon dioxide level, and you tolerate a slightly lower blood pH in order to protect the lung from being blown apart by the ventilator.
That makes sense.
The trial mandated keeping the plateau pressure, the static pressure inside the lung under 30 centimeters of water, and the driving pressure under 15. By adhering to those mechanical limits, the mortality benefit was undeniable. It saved countless lives by teaching doctors to do less.
It's an incredible lesson in humility. The machine can hurt just as much as it helps, which requires intense vigilance from the medical team. They have to constantly monitor the physical mechanics of the lung.
They do.
The text spends a lot of time differentiating between static compliance and dynamic compliance. I want to make sure I understand this.
Sure. Compliance is simply a measure of how stretchy or how accommodating a structure is. High compliance means it stretches easily, like a new rubber band.
Okay.
Low compliance means it's stiff, like a heavy bungee cord. In the lungs, static compliance measures the elastic properties of the lung tissue and the chest wall itself, measured when there is absolutely zero airflow.
So it's still.
Yes. Imagine taking a deep breath and holding it. The pressure it takes to hold that volume is your static compliance.
Okay, and dynamic compliance.
Dynamic compliance measures everything static does, but it adds the element of resistance because it's measured while air is actively moving through the airways.
Let me try an analogy here. Imagine a balloon attached to the end of a drinking straw.
Perfect. Static compliance is measuring how stiff the rubber of the balloon is.
Right.
Dynamic compliance includes the stiffness of the balloon, plus how narrow or gunky the straw is while you are actively blowing through it.
Okay, so translating that to the ICU monitors.
Yeah.
We track two main pressures on the ventilator. The peak inspiratory pressure, the PIP, which is the absolute highest pressure reached while air is actively flowing in, and the plateau pressure, the P-plat, which is the pressure during a brief pause when airflow stops before they exhale.
Exactly.
The board pearls highlight a brilliant diagnostic trick here for when a ventilator suddenly starts alarming.
Yes, it's a classic bedside conundrum. The high-pressure alarm goes off. What do you do?
So if the peak inspiratory pressure suddenly spikes, but you check the plateau pressure and it has stayed completely stable, what is happening?
That is a pure resistance problem. The balloon is fine, but the straw is suddenly blocked. The pressure to push air through the tubes is high, but once it's in the lung, the holding pressure is normal. Clinically, it means the patient might have a massive mucus plug in their airway, or they're having a sudden asthma attack causing bronchospasm, or maybe they're just waking up and physically biting down on the plastic endotracheal tube. You treat the tube, not the lung.
But if both the peak pressure and the plateau pressure rise equally at the same time?
That is a compliance problem. The straw is perfectly clear, but the balloon itself has become incredibly stiff.
Which means the lung is failing.
Right. That tells you the disease process in the lung tissue is severely worsening. The ARDS is progressing, or perhaps they've developed a massive pneumonia. Or worst of all, the lung has popped and created a tension pneumothorax.
Oh, man.
Yeah, air trapped in the chest cavity, crushing the lung. It demands a completely different, immediate, life-saving intervention.
Before we leave the pulmonary system entirely, I was marveling at this closing point for severe ARDS. You have these multi-million-dollar mechanical ventilators, incredibly complex paralytic and sedative pharmacology, intricate pressure monitoring. And yet, one of the most effective, statistically proven life-saving interventions for these patients is incredibly low-tech.
It really is.
It's just flipping the patient over.
Prone positioning. It is astonishingly effective and deeply humbling for a field that loves high-tech solutions. The Perseva trial proved that placing a severe ARDS patient in the prone position lying flat on their stomach for at least 16 hours a day significantly reduces mortality.
But wait, how does simply lying on your stomach do the work of all these machines?
Well, think about the physical anatomy of the human chest. The majority of your lung mass is actually situated towards your back.
Oh, really?
Yes. When you lie supine, on your back, the massive weight of your heart plus the weight of your abdominal organs pushing up against your diaphragm physically crushes the back halves of your lungs, the dependent regions.
And in ARDS, those lungs are already heavy and filled with fluid.
Exactly. So those crushed heavy areas at the back completely collapse. Blood still flows through them, but no oxygen gets in, creating a massive shunt.
Okay, so when you flip them,
By bringing in a team and carefully flipping the patient onto their stomach, you completely offload that weight. The heart falls forward onto the sternum, the belly hangs down. Suddenly, those massive areas of collapsed lung tissue in the back just pop open.
wow.
They can participate in gas exchange again. It perfectly recruits the damaged alveoli. It improves ventilation perfusion matching, and it allows you to oxygenate the blood without needing to increase those dangerous ventilator pressures.
It's literally using gravity as a medical intervention. Incredible.
Absolutely.
All right, so we have finally secured the oxygen, but oxygen sitting in the warehouse of the lungs is utterly useless unless we can get it into the delivery drugs and pump it to the brain, the kidneys, and the liver.
We need transport.
Right. That means we have to transition to the cardiovascular system, the pump and the pipes. Hemodynamic resuscitation. This accounts for another 17.5% of the board exam.
And I would argue it is the most intensely dynamic aspect of critical care medicine. I mean, pulmonary mechanics can change over hours. Hemodynamics change second by second.
The text makes a really elegant analogy here. To understand how blood moves through the body, it compares the human cardiovascular system to a basic electrical circuit. It relies on Ohm's law of the body. Mean arterial pressure minus central venous pressure equals cardiac output multiplied by systemic vascular resistance.
It maps perfectly to basic electronics or even household plumbing. You are dealing with pressure, flow, and resistance.
Yeah.
Mean arterial pressure, or MAP, is the overall driving pressure pushing blood forward. Central venous pressure, CVP, is the backup pressure on the right side of the heart, like the end of the line. Cardiac output, SCO, is the actual flow rate of the pump. And systemic vascular resistance, SVR, is how tightly the pipes, the arterial blood vessels, are squeezed.
Okay, let's play a game with this, because this is how the boards actually test it. I want to challenge you to explain the 4 types of shock, like a diagnostic puzzle.
I love it. Let's do it.
A patient crashes, their blood pressure plummets, they're dying. How do you know which of the 4 distinct types of shock is killing them? Just by looking at how those variables change. Let's start with hypovolemic shock.
Yeah.
Say, a massive hemorrhage from a car accident.
Okay, so in hypovolemic shock, the fundamental problem is that the pipes are empty. You've bled out or you're profoundly dehydrated.
Okay.
Because there's no volume returning to the heart, the central venous pressure is drastically low. And because the heart has no blood to pump, cardiac output drops.
Right.
But the body is incredibly smart. To try and maintain enough driving pressure to keep the brain alive, it releases massive amounts of adrenaline to clamp down on all the peripheral blood vessels. So systemic vascular resistance skyrockets as a compensatory squeeze. Low flow, high resistance, empty tank.
That makes intuitive sense. Puzzle 2, cardiogenic shock.
Yeah.
Like a massive heart attack.
Here, the tank is perfectly full, but the pump itself is broken. A massive chunk of the heart muscle has died. Cardiac output plummets because it can't squeeze.
Okay.
Because the blood can't move forward, it backs up into the lungs and the venous system. So central venous pressure shoots way up. And once again, the body senses the low forward flow and tries to compensate by clamping the vessels so SVR is high. Low flow, high resistance, overflowing tank.
Puzzle 3. And this is the one that fills medical ICUs every day.
Yeah.
Distributive shock. Classic sepsis. I want to try this one.
Go for it.
If it's a massive infection, the bacteria release toxins that cause the blood vessels to basically lose all their tone, right?
Exactly. The primary defect in sepsis is a total loss of vascular tone.
So the pipes just dilate wide open. That means the systemic vascular resistance drops through the floor. The pipes are huge. So how does the heart react?
Well, because the resistance suddenly disappears, the heart actually beats faster and harder early on to try and fill those massively dilated pipes. So paradoxically, cardiac output is initially high in early distributive shock. Yeah, but because the pipes are so wide and leaky, blood pools in the extreme periphery of the body and very little makes it back to the heart. So central venous pressure remains low, high flow, terribly low resistance.
It's the only shock with a high cardiac output early on.
Yes.
Finally, obstructive shock.
Yeah.
A massive pulmonary embolism, a blood clot in the lung or cardiac tamponade, which is fluid crushing the heart.
In this case, the flow is physically blocked by an external force. In a massive PE, a huge blood clot chokes off the pulmonary artery. The right side of the heart is pumping against a literal wall.
So output drops.
Cardiac output drops,
Right.
and SVR rises to compensate. But because the blood is hitting that wall in the lungs, it backs up violently into the venous system. Central venous pressure gets incredibly high, which you can physically see as bulging jugular veins in the patient's neck.
Wow.
And in cardiac tamponade, blood fills the sac surrounding the heart, physically squeezing it so it can't expand and fill. The hallmark diagnostic clue there is the equalization of all the diastolic filling pressures across every chamber of the heart. Everything is squeezed equally.
So once you solve the physiological puzzle and know what type of shock you're dealing with, you have to treat it. Which brings us to the pharmacology of resuscitation. Vasopressors.
Yes, the pressor.
These are the intravenous drugs that chemically squeeze the pipes to restore blood pressure. The board pearls list norepinephrine as the absolute reigning champion for distributive shock like sepsis.
Yes. Norepinephrine acts on alpha-1 adrenergic receptors in the blood vessels and beta-1 receptors in the heart. It provides a powerful, sustained squeeze to the peripheral pipes while giving a gentle, supportive kick to the heart's contractility to keep flow moving.
But, I have to push back on this because it seems entirely counterintuitive to me. If a patient is in profound septic shock, their organs, especially the kidneys, are already starving for blood flow.
Right.
Doesn't giving a massive vasoconstrictor drug like norepinephrine just clamp down the kidney arteries even more and choke off the organ entirely?
It's a fantastic question, and historically, for decades, doctors feared exactly that. There was a huge reluctance to use pressors because they thought they would cause renal failure. But modern critical care has proven this is a myth in the context of profound shock.
How so?
Here is why. The kidneys are mechanical filters. They require a minimum driving pressure of blood flow to push fluid across the filtration membrane. This is called the autoregulatory threshold. Usually that requires a mean arterial pressure of at least 60 to 65 millimeters of mercury.
Okay, so they need a baseline pressure.
Right. In severe septic shock, the patient's MAP might be 40. The overall driving pressure is so low that the kidneys aren't filtering a single drop of urine, regardless of how wide open their local vessels might be.
I see.
By giving norepinephrine, you heavily squeeze the systemic pipes, which restores the overall mean arterial pressure above that critical threshold of 65.
So you provide the driving force.
Exactly. You push the overall head of pressure high enough that you actually improve the glomerular filtration gradient in the kidney. Squeezing the system saves the filter. You will literally watch a patient who hasn't made a drop of urine all day suddenly start producing clear urine the moment the norepinephrine drip gets their blood pressure up.
That is wild. Now, here's where it gets really interesting. Let's look at a post-cardiac arrest scenario. Someone's heart stops, bystanders do CPR, paramedics give drugs, they get the heart restarted, and they bring them to the ICU.
A very common scenario.
But the patient is profoundly hypotensive. They are in shock. The text explicitly warns doctors against using epinephrine as a continuous drip to keep the blood pressure up in this exact scenario.
Wow.
I mean, epinephrine is literally the famous drug we use to restart the heart during CPR.
It is the perfect drug for a dead heart, but it is a terrible drug for a recovering heart.
Oh.
Once you get return of spontaneous circulation, a continuous intravenous drip of epinephrine acts like whipping an utterly exhausted horse.
Explain the cellular mechanism there.
Sure. Epinephrine is a massive beta-1 agonist. It forces the heart muscle to beat incredibly fast and squeeze incredibly hard. This massively spikes myocardial oxygen demand.
All right.
You are forcing a heart that just died and is already starving for oxygen to run a chemical marathon. Furthermore, epinephrine is highly arrhythmogenic. It irritates the electrical conduction system of the heart, triggering chaotic rhythms.
So it could stop again.
If the patient had a massive heart attack that caused the arrest in the first place, putting them on an epi-drip will burn out whatever healthy tissue is left and likely throw them right back into a fatal ventricular fibrillation. You want norepinephrine instead. It gives you the blood pressure you need without whipping the heart to death.
Okay, but what if norepinephrine isn't enough? You're at the maximum safe dose, the monitor is blaring, and the blood pressure is still in the boots. The patient is dying of vasodilatory shock.
Yeah.
What is the second-line agent?
The standard second-line agent is vasopressin. And the mechanism here is brilliant because it bypasses the adrenergic receptors entirely.
What do you mean?
Norepinephrine works by binding to alpha and beta receptors. But in severe, prolonged sepsis, the blood becomes highly acidic. The body releases massive amounts of its own native adrenaline. Over hours, those alpha and beta receptors get fatigued, they get downregulated, and they're physically warped by the acid.
They just wear out.
They become numb to the norepinephrine you are pumping in. Vasopressin acts on a completely different set of receptors, V1 receptors located directly on the smooth muscle of the blood vessels. It provides a powerful, independent squeeze, even when the primary adrenergic system is totally burned out.
It's like having a backdoor into the vascular system.
Yes.
The pearls also mention a drug called landiol for sepsis, complicated by very rapid heart rates, but immediately throws cold water on it.
Yes, landiolol is a super short-acting beta blocker. The logic was, if a septic patient's heart is racing at 140 beats a minute, they are burning too much cardiac energy. Let's give a beta blocker to slow the heart down and make it more efficient.
Sounds logical.
But recent randomized trials showed this actually increased mortality and led to higher requirements for other vasopressors. The board pearls advise extreme caution because it's a classic example of treating a fast heart rate while ignoring why the body is doing it.
Right.
The heart is racing to compensate for the shock. If you take away the compensation, the system crashes.
Speaking of old medical dogma crashing down,
Yep.
Let's talk about fluids and steroids, because this is where landmark clinical trials have completely flipped the script in the last decade. For the longest time, the absolute golden rule for sepsis was just pump them full of fluids.
Right. The era of early goal-directed therapy. Originating from the Rivers trial in 2001, the protocol dictated giving liters upon liters of normal saline to hit specific pressure targets.
But the source material brings up two massive recent trials.
Yeah.
The Clovers trial and the Classic trial. What did they find?
They challenged the fluid dogma entirely. Both trials looked at patients in septic shock who had already received their initial standard fluid challenge, usually about 1 to 3 liters of FOB fluids. After that initial phase, they randomized patients. One group aggressively got more and more fluids every time their blood pressure dropped. The other group was strictly fluid restricted, and doctors started vasopressors like norepinephrine much earlier instead.
And the result?
0 difference in 90-day mortality. In fact, pumping patients blindly with more and more fluids after the initial resuscitation was deeply harmful. The fluid doesn't stay in the blood vessels, it leaks out into the tissues.
They just swell up.
The patients swell up like balloons, their lungs get boggy, making it harder to get them off the ventilator. Their kidneys swell inside their fibrous capsules, actually worsening kidney injury. The trials prove that beyond the first few liters, aggressive fluid resuscitation does not save lives. It just causes horrific fluid overload complications down the line.
So what's the ultimate takeaway for the listener?
The takeaway is that critical care resuscitation must be dynamic and constantly personalized. You give the initial fluid challenge, and then you stop. You actively assess the patient. Are they actually fluid responsive? Can their heart even handle more volume? Or do they need a pressor to squeeze what they already have? Rigid, algorithmic protocols kill patients in the nuanced phases of critical care.
We see that exact same nuance with the use of steroids in septic shock. The text contrasts two massive trials.
Yeah.
The adrenal trial versus the APROCHE-HSS trial.
Right. For a long time, we knew that giving steroids could help restore blood pressure in severe shock, but the exact regimen was debated. The adrenal trial showed that giving an infusion of hydrocortisone alone didn't improve overall 90-day survival, though it did help patients get off vasopressors a little faster.
Okay, but what about the other one?
The APROCHE-HSS trial did something different. They gave hydrocortisone plus an oral steroid called fludrocortisone, and that combination did show a mortality benefit.
Why the difference? Like, what is fludrocortisone doing?
It comes down to the two different pathways of the adrenal axis. Hydrocortisone primarily provides glucocorticoid activity. It powerfully blunts the systemic inflammatory response.
Okay.
But fludrocortisone is a potent mineralocorticoid. It acts directly on the kidneys to retain sodium and water, and it dramatically increases the sensitivity of the blood vessels to your own native adrenaline. You need both the anti-inflammatory effect and the vascular tone enhancement to fully reverse the shock state.
Let's close out the cardiovascular section with the TAPI trial regarding blood transfusions. For a very long time, ICU doctors have fiercely loved the restrictive transfusion strategy, meaning do not give a blood transfusion unless the patient's hemoglobin drops dangerously low, usually below 7 grams per deciliter.
Yes, that's been standard practice.
But the TAPI trial added a massive specific caveat to this rule.
It did, and it's a brilliant distinction. Restrictive transfusion is generally excellent for medical ICU patients. Blood transfusions carry risks of infection, immune reactions, and lung injury. So waiting until the hemoglobin is under 7 is smart.
Right.
But the TOP trial specifically looked at patients undergoing major high-risk surgery who had a history of cardiac disease. In that highly specific population, rigidly waiting until the hemoglobin dropped below 7 before transfusing actually led to significantly more cardiac complications like heart attacks during recovery compared to a liberal strategy of keeping the hemoglobin above 10.
Why? Why is it different for them?
Because the heart muscle itself requires a massive amount of oxygen during the physiological stress of major surgery. If you strictly withhold red blood cells, which are the oxygen delivery trucks, just to adhere to a rigid ICU dogma, you end up starving the heart muscle of oxygen precisely when it needs it most. Context is everything.
Context is everything. I love that.
Yeah.
All right, so we have the oxygen, we have the blood pressure stabilized. Let's move down the line to the organs actively receiving that blood. We are moving to section 3, the filters and the hormones. Renal and endocrine crises. This makes up another 15% of the board exam. Let's start with the kidneys. Acute kidney injury, or AKI.
The kidney is the ultimate victim in the ICU. It is incredibly selfish with blood flow. Despite being relatively small organs, the kidneys demand 20% of the entire cardiac output at all times to filter the blood.
Wow, 20%.
So any drop in systemic blood pressure hits the kidneys first and hardest. The boards rely on the KDI-GO criteria to stage the severity of the injury.
KDI-GO standing for kidney disease. Improving global outcomes. What are they looking for?
They look at two primary things: the bump in serum creatinine, which is a waste product the kidney normally clears, and the drop in urine output. And the thresholds are incredibly sensitive. Even a tiny bump in creatinine of just 0.3 milligrams per deciliter within a 48-hour window categorizes a patient as having stage 1 AKI.
The kidney lets you know very early that it is struggling.
Exactly.
But when does a doctor decide, okay, the kidney is entirely done, waiting isn't going to work, we need to put a giant catheter in their neck vein and start continuous dialysis, or renal replacement therapy, RRT?
The board pearls list the absolute indications for initiating RRT. You step in when the kidney's failure is immediately life-threatening. This includes refractory acidemia, meaning their blood is turning to acid, and massive intravenous bicarbonate drips just aren't working.
Okay.
Severe hyperkalemia, potassium levels rising so high they're about to literally stop the heart's electrical system. Massive volume overload where the kidneys can't make urine and the patient's lungs are drowning in their own fluid. And specific toxic ingestions like massive overdoses of aspirin or lithium, where you physically have to use a dialysis machine to filter the poison out of the blood because the kidneys are overwhelmed.
You mentioned acidemia. Acid-base math is a massive, incredibly complex part of critical care. To figure out why a patient's blood is acidic, the text mentions the classic mud to piles mnemonic.
Yes, Muddy Piles is the gold standard memory aid for an elevated anion gap metabolic acidosis. The anion gap is a calculation of the charged ions in the blood. If the gap is wide, it tells you there is a hidden, unmeasured acid circulating in the patient's system.
Right, and mud pile stands for methanol, uremia, which is kidney failure, diabetic ketoacidosis, propylene glycol, isoniazid, lactic acidosis from shock, ethylene glycol, which is antifreeze, and salicylates, which is aspirin.
You got it.
But the board pros go a step further than just finding the gap. They want candidates to calculate the delta-delta ratio.
Yeah.
Now, this sounds like advanced accounting again. What is the delta-delta ratio, and what is the biological mechanism it reveals?
It's a brilliant piece of physiological detective work. The delta-delta ratio looks at how much the anion gap went up compared to how much the blood bicarbonate, the body's natural base, went down. In a simple, mathematically perfect world, one molecule of hidden acid consumes exactly one molecule of bicarbonate buffer. It should be a 1-to-1 ratio.
Okay, so the gap goes up by 10, the bicarb should drop by 10.
Exactly. But if you do the math and the ratio is significantly off, it reveals that a hidden second concurrent disorder is happening simultaneously. For example, if the gap went up by 10, but the bicarbonate only dropped by 2, that means the patient has way too much bicarbonate left over. It tells you that in addition to the hidden acid, the patient also has a primary metabolic alkalosis hiding in the background.
From what?
Perhaps they've been vomiting severely for days, losing stomach acid, which artificially raised their baseline bicarb before the new acid arrived. Calculating the delta-delta allows you to untangle complex, mixed acid-base disorders that would otherwise be completely invisible.
It's literally like finding two entirely different poisons at a crime scene.
Yes.
And what if the primary problem is respiratory? What if the acid is carbon dioxide because the patient isn't breathing enough?
Yeah.
How does the kidney compensate for that?
The kidney is the ultimate long-term buffer. If the lungs fail and CO2 builds up in the blood, creating a respiratory acidosis, the kidney tries to save the patient by holding on to bicarbonate base to neutralize the acid. But the mechanism is time-dependent.
Meaning it takes a while.
Right. In an acute crisis, say a sudden asthma attack, the kidney's machinery is just too slow. Bicarbonate only rises by 1 milliequivalent for every 10 points the CO2 goes up.
But if it's chronic,
If it's a chronic problem, like a patient with severe COPD who has been retaining CO2 for months, the kidney physically revs up its cellular machinery to reabsorb massive amounts of bicarb. Over 3 to 5 days, the bicarb compensation will rise by 3 to 4 points for every 10 points of CO2. By looking at a single blood gas, the math tells you exactly how long the patient's respiratory system has been failing.
that brings us perfectly to the metabolic control systems, the endocrine emergencies, specifically glycemic crises, DKA versus HHS, diabetic ketoacidosis, and hyperosmolar hyperglycemic state. Now, I know they both involve crazy high blood sugar, but biologically, how do we distinguish them?
The fundamental distinction lies in the absolute versus relative lack of insulin. In DKA, which usually occurs in type 1 diabetics, there is absolute zero insulin in the body.
Right.
Because the body's cells cannot absorb or use glucose without insulin acting as the key to the door, the cells think they are entirely starving, even though the blood is coming in sugar.
So the body panics and looks for a different fuel source.
Exactly. It aggressively breaks down fat stores, a process called lipolysis. Those broken down free fatty acids flood the liver, which converts them into massive amounts of ketones for emergency brain fuel. But those ketones are highly acidic. They dump hydrogen ions into the blood, hence diabetic ketoacidosis.
And what about HHS?
In HHS, which typically occurs in older type 2 diabetics, there is a tiny residual trickle of insulin still being made by the pancreas. It's not nearly enough to keep the blood sugar normal. The sugar can store to 800, other 1,000, or even 1,200. But that tiny bit of circulating insulin is just enough to tell the liver, hey, we aren't completely starving, don't initiate lipolysis, don't make ketones.
So you don't get the severe acid. but you still have blood that is basically syrup.
Right. And because the sugar is so incredibly high, it acts as a massive osmotic diuretic in the kidneys. It pulls water out of the body and forces it into the urine. The patient pees out liters and liters of pure water, becoming incredibly, life-threateningly dehydrated. They die of profound hyperosmolarity and shock, not acid.
Now, here is a massive clinical pearl for you listening, and it highlights just how dangerous the ICU can be. This is the potassium trap in DKA. It is literally a life-or-death detail.
Pay attention to this one.
Imagine a 25-year-old patient rolls into the ER with raging DKA. They're breathing incredibly fast. They're confused. You check their initial labs. Their serum potassium level on the monitor looks totally normal, maybe even a little high. So your instinct is great. Their potassium is fine. Let's start the life-saving continuous intravenous insulin drip right now. Why is that an immediate fatal mistake?
Because the number on the lab report is lying to you about the total body stores.
Explain that.
In DKA, the blood is profoundly acidic. The body tries to buffer that acid by pushing the excess hydrogen ions into the cells. To maintain electrical neutrality across the cell membrane, the cells have to kick something positive out.
Like a swap.
Yes, they kick potassium out into the blood, so the blood draw looks like it's full of potassium, but in reality, the patient has been peeing that excess potassium out into the toilet for days due to the osmotic diuresis. Their total body potassium stores are actually severely depleted.
So what happens if you give the insulin?
Insulin is the master key. It forcefully drives glucose and potassium back into the cells. If you start an insulin drip without checking and aggressively replacing potassium first, that artificially normal blood potassium level will instantly plummet to near zero as the insulin forces it all back into the empty cells.
Wow.
And because the heart relies on serum potassium to maintain its electrical rhythm, the patient will go into a fatal cardiac arrhythmia-like ventricular fibrillation right in front of you. You must delay the life-saving insulin until the potassium is secured and repleted.
Wow. You have to actively disarm the trap before you can treat the disease.
Exactly.
Let's look at the other extreme of the endocrine system, the thyroid gland. Thyroid storm versus myxedema coma. Let's start with a thyroid storm. The patient's thyroid has gone rogue. They are hypermetabolic, 105-degree fever, heart rate of 160, altered mental status, severe agitation. The board pearls dictate that the exact sequence of the medications you give is absolutely crucial. Walk us through it.
It is a highly precise pharmacological sequence that you cannot mix up. Step 1. You must block the synthesis of new thyroid hormone deep inside the gland using drugs like propylthiouracil, PTU, or methimazole. Step 2. You block the release of the already manufactured hormone using inorganic iodine.
Okay, let me stop you right there. Why that exact order? Why wouldn't you give the iodine first to instantly slam the door shut and stop the release of the hormone into the blood?
If we connect this to the bigger picture of how the thyroid functions, iodine is the essential raw material, the building block that the thyroid uses to manufacture its hormone. The hyperactive thyroid in a storm is starving for iodine.
So it's like Lucille Ball at the chocolate factory assembly line. If you just dump a massive bucket of raw ingredients onto the conveyor belt without physically shutting down the processing machinery first, you are just going to create a catastrophic overflow.
That is the exact mechanism. If you give a massive dose of iodine before you block the synthesis machinery with PTU, the starving thyroid will rapidly absorb all that new iodine and churn out even more deadly hormone.
Yikes.
This is a physiological phenomenon called the Wolff-Chaikoff effect, and it will paradoxically pour fuel on the fire, drastically worsening the storm and potentially killing the patient. You must shut the factory machinery down with PTU first, wait an hour for it to take effect, and then give the iodine to block the release stores.
That is incredible. And then what are the final steps?
Step 3, you give high-dose corticosteroids. This stops the peripheral conversion of the inactive T4 thyroid hormone into the highly active, dangerous T3 hormone in the body tissues. And step 4, you give beta blockers, like propranolol, to shield the heart and brain from the massive circulating sympathetic nervous system surge.
Now, let's look at the absolute opposite end of the spectrum. Myxedema coma. Profound, life-threatening hypothyroidism.
The patient is in total systemic shutdown. They are freezing cold with a core temp of 90 degrees. Their heart rate is in the 30s. They have low blood pressure and severely depressed breathing. They often have this very distinctive non-pitting edema everywhere because complex sugars, called mucopolysaccharides, physically build up in the deep layers of the skin due to the lack of metabolic clearance.
The treatment here seems obvious. They have no thyroid hormone, so you give them intravenous thyroid hormone. But again, the board pearls reveal a hidden, lethal trap. What is the life-saving step you have to take before giving the levothyroxine?
You must give intravenous hydrocortisone, a stress steroid, first.
Why? Why do steroids matter before the thyroid hormone?
Because patients with profound, long-standing hypothyroidism often have concurrent, undiagnosed primary adrenal insufficiency. Their entire body has been running in slow motion for months, including their baseline metabolic rate. Their adrenal glands haven't had to produce cortisol, the body's main stress hormone, in a long time.
So they're unprepared.
Right. If you suddenly hit them with a massive IV dose of active thyroid hormone, you instantly rev their metabolic engine up from 10 miles an hour to 100 miles an hour.
But without a functioning adrenal gland.
Without the adrenal gland to provide the stress hormone cortisol needed to support that sudden, massive metabolic demand, you will trigger an acute adrenal crisis. Their vascular tone will collapse, their blood pressure will drop to zero, and they will die. You have to preload the system with stress hormones to support the cardiovascular system before you turn the metabolic key.
The human body is just a breathtaking series of interlocking dependencies.
It really is.
Let's transition to Section 4, the invaders and the control center, infectious disease and neurocritical care. Because a body in multi-system crisis is incredibly vulnerable to bacterial invasion, and if the systems fail entirely, the brain, the supercomputer, is the ultimate casualty.
Absolutely.
Let's talk antimicrobial nuance. The text pushes very hard on targeted durations. We don't just put people on broad-spectrum antibiotics indefinitely anymore.
Absolutely not. Antimicrobial stewardship is paramount in the modern ICU. For a severe MRSA pneumonia, the target is exactly 8 days of therapy. For a virulent Pseudomonas infection, it's 14 days. The goal is to aggressively eradicate the specific pathogen without continuously bombing the microbiome and breeding multi-drug-resistant superbugs that will kill the patient next month.
And there's a fascinating drug interaction mentioned here that I want to explore. The daptomycin trap. Daptomycin is an amazing, heavy-hitting intravenous antibiotic, right? It's the gold standard for MRSA blood infections and MRSA endocarditis in the heart. But the text emphatically states that daptomycin is strictly forbidden for treating MRSA pneumonia in the lungs. Why? It's the exact same bacteria.
It is the exact same bacteria, but it is a profoundly different microenvironment. It's a beautiful piece of biochemistry. Daptomycin is a large, complex lipopeptide molecule. When it circulates in the blood, it's highly effective. But when it enters the alveoli of the lungs, it encounters pulmonary surfactant.
Surfactant being the soapy, lipid-based liquid our bodies produce to reduce surface tension and keep the tiny air sacs from collapsing.
Right. When the daptomycin molecule hits that lipid-rich surfactant, the surfactant chemically binds to the drug and completely sequesters and destroys its active site. So you can pump as much intravenous daptomycin into the patient as you want. The moment it crosses into the lung space, it is instantly neutralized by the body's own soap. The pneumonia will rage on entirely unhindered. You have to rely on different antibiotics like linezolid or vancomycin, whose molecular structures are immune to surfactant.
And the Pearl notes that with vancomycin and severe pneumonia, the target trough level, the lowest concentration in the blood just before the next dose, needs to be aggressively high, around 15 to 20 micrograms per milliliter, to ensure enough drug physically penetrates the dense lung tissue.
Right.
Here's another infectious disease connection that absolutely blew my mind. Cirrhosis and GI bleeds. Imagine a patient with end-stage liver failure comes into the ICU throwing up massive amounts of blood from ruptured varices in their esophagus or stomach. Why on earth is it standard life-saving protocol to immediately start them on IV antibiotics like ceftriaxone? They're bleeding from a ruptured vein, they don't have a fever, they aren't infected.
This perfectly highlights the deeply interconnected gut-liver axis. When a patient with severe cirrhosis suffers a massive gastrointestinal bleed, two catastrophic things happen simultaneously. First, the massive amount of blood pooling in their intestines provides a huge protein load that the gut bacteria start breaking down, producing ammonia.
Okay.
But more importantly, the physical state of hypovolemic shock and the sudden lack of blood flow to the gut wall during the hemorrhage causes the intestinal mucosa to break down. The physical barrier fails.
And the gut is full of trillions of bacteria.
Exactly. Bacteria that normally live peacefully inside the lumen of the intestine suddenly translocate. They physically leak across the damaged gut wall directly into the bloodstream and into the sterile, acidic fluid of the abdomen.
And because their liver is failing, their immune system, specifically the Kupffer cells in the liver that usually clear those bacteria, is already severely compromised.
Precisely. They are at incredibly high risk for developing spontaneous bacterial peritonitis, a lethal infection of the belly fluid, and overwhelming gram-negative sepsis. The physical act of bleeding literally opens the door for the bacterial invaders. Giving a broad-spectrum antibiotic like ceftriaxone prophylactically shuts that door and has been proven in multiple trials to significantly reduce mortality in these bleeders.
Let's move from the gut to the absolute control center, the brain. Neurocritical care. The text uses an analogy for the Monroe-Kelly doctrine that I want to expand on because it visualizes the problem perfectly. Think of the human skull like a tightly packed, rigid, hard-shell suitcase.
That is the perfect conceptualization. The skull is thick bone, it does not expand, it does not yield. Inside that rigid suitcase, you have exactly three things. Brain tissue, which is about 80%, cerebrospinal fluid, or CSF, at about 10%, and blood at about 10%.
The Monroe-Kelly doctrine states that because the total volume of the suitcase is fixed, if one of those three things increases in volume, one or both of the other two must decrease, or the pressure inside the suitcase will skyrocket.
Right. If you have a massive traumatic brain bleed or a fast-growing tumor, or the brain tissue itself swells from a hypoxic injury, the volume goes up.
Where does it go?
Well, the body tries to compensate initially by squeezing CSF down out of the head into the spinal cord and squeezing venous blood out of the jugular veins. But once those very limited compensatory mechanisms are exhausted, you hit the steep part of the compliance curve. The intracranial pressure, or ICP, shoots up exponentially.
And if the pressure inside the rigid suitcase gets too high?
The brain has literally nowhere to go but down, through the only exit available. The hole at the base of the skull, called the foramen magnum. This is called brain herniation. The swelling brain physically crushes the brainstem, which controls your basic drive to breathe and your heart rate, and it is rapidly, inevitably fatal.
The math here is simple but terrifying. Cerebral perfusion, pressure CPP, which is the actual pressure of blood reaching the brain tissue, equals mean. Arterial pressure, MAP, minus intracranial pressure, ICP. If ICP goes up, blood physically cannot push its way into the brain to deliver oxygen. The brain starves. So how do we treat this? The text outlines a tiered algorithm. Tier 1 seems fairly foundational.
Tier 1 is about optimizing the plumbing. Elevate the head of the bed to 30 degrees to let gravity help drain the venous blood out of the head. Heavily sedate the patient so their brain isn't burning excess oxygen and demanding more arterial blood flow. And give hyperosmolar therapy like intravenous mannitol or super salty hypertonic saline.
Because the high concentration of salt in the blood acts like a chemical sponge, crossing the blood-brain barrier and literally sucking the extra water out of the swollen brain tissue.
Precisely. You medically shrink the brain tissue to make more room in the suitcase.
But what if Tier 1 fails? The ICP monitor bolted into their skull is still spiking. The alarms are going off. We move to Tier 2. The main intervention here is transient hyperventilation on the mechanical ventilator.
Yeah.
So what does this all mean? How does breathing fast lower the pressure inside the brain?
This is one of the most elegant yet incredibly dangerous physiological hacks we possess. By intentionally hyperventilating the patient, increasing the breathing rate on the ventilator, you blow off massive amounts of carbon dioxide. You make the blood hypocapnic.
Okay.
The arterial blood vessels in the brain are exquisitely sensitive to the exact level of CO2. When CO2 drops, the cerebral arteries profoundly vasoconstrict. They clamp shut.
If the arteries clamp shut, there is physically less arterial blood volume inside the rigid suitcase.
Exactly. ICP drops almost instantly. It can save a patient from herniating and dying right in front of you, but it is incredibly dangerous.
Right.
If you clamp those cerebral blood vessels too tightly for too long, you cause severe cerebral ischemia. You literally starve the healthy brain tissue of blood and cause massive secondary strokes. It is a temporary bridge-to-life measure only, usually used just to buy time to get the patient to the operating room.
Which leads to Tier 3, the absolute last resorts.
Oh.
Putting the patient into a deep barbiturate coma to completely paralyze all brain metabolism, or calling the neurosurgeon to literally take a saw, remove a massive chunk of the skull bone, and let the swelling brain bulge out the side of the head, a decompressive craniectomy. The stakes are just unbelievably high.
Yeah.
Let's quickly touch on status epilepticus while we're in the brain. Seizures that won't stop. The text is very strict on the timeline here.
Time is brain in status epilepticus. Every single minute a seizure continues, it becomes exponentially harder to stop because the GABA receptors in the brain physically internalize and change their structure due to the constant electrical firing.
So what's the first move?
In the first 5 to 20 minutes, you must give benzodiazepines. Intravenous lorazepam or intramuscular midazolam. They are the fastest, most effective electrical circuit breakers we have.
And if that initial circuit breaker doesn't work?
You move instantly to phase 2. Non-benzodiazepine anti-epileptic loading doses, levetiracetam, phosphonetoin, or Velpro. If they are still seizing after that, you are in refractory status. You must paralyze and intubate the patient, put them on a ventilator, and blast them with continuous anesthetic infusions like propofol or midazolam until the EEG monitor shows burst suppression.
Meaning you have pharmacologically silenced the electrical storm in the brain to a flat line with only occasional bursts of activity. And a very quick stroke update for the neurologists. The OPTION and TRACE-5 trials are highlighted in the pearls. They are shifting the paradigm away from the old standard clotbuster, TPA, to a newer drug called tenecteplase for specific large vessel occlusion strokes up to 24 hours out. It's much more fibrin-specific, it's easier to administer as a single rapid IV push rather than a prolonged drip, and it represents the absolute cutting edge of stroke neuroresuscitation.
It's a game changer.
Okay, deep breath. We are entering the final leg of our journey. Section 5, the cascade of chaos. GI, tox, and HEMOC. These are rapid-fire, insanely high-stakes system failures where specific scoring systems and highly specific antidotes rule the day. Let's start with gastrointestinal emergencies, acute liver failure or ALF.
Acute liver failure is terrifying to manage because the liver is the body's primary chemical processing plant. It does everything. It clears metabolic toxins, it processes drugs, and it synthesizes the proteins that make your blood clot. When it fails acutely in someone without prior liver disease, they rapidly develop profound coagulopathy. They bleed from everywhere. And hepatic encephalopathy, their brain gets severely poisoned and swells from the buildup of ammonia.
The board pearls emphasize the King's College criteria for deciding who needs to be immediately listed for an emergency liver transplant, and it explicitly splits it into two buckets: acetaminophen or Tylenol toxicity versus everything else. Let's focus on acetaminophen. It's in literally everyone's medicine cabinet, but it is a leading cause of fatal ALF.
The King's College criteria for Tylenol overdose are brutal. They state that if a patient with an acetaminophen overdose has an arterial pH of less than 7.3, a severe metabolic acidemia after aggressive fluid resuscitation, that single number is a massive red flag.
Just one number.
It indicates widespread, irreversible mitochondrial failure and impending death. They need a transplant immediately.
But what if the pH is okay, greater than 7.3? Are they safe?
Not necessarily. If the pH is fine, you have to look for a specific triad of terror. You need an INR greater than 6.5, meaning their blood is so thin it basically won't clot at all. You need a serum creatinine greater than 3.4, meaning the liver failure has cascaded and caused their kidneys to entirely collapse. And you need severe encephalopathy, grade 3 or 4 encephalopathy, meaning they are deeply comatose.
Man.
If they hit all three of those criteria simultaneously, call the transplant surgeon immediately because the liver is not going to recover on its own.
What about severe pancreatitis?
Yeah.
The text mentions Ranson's criteria.
Severe acute pancreatitis is when the pancreas, which normally secretes digestive enzymes into the gut, becomes inflamed and starts literally digesting itself. It leaks those highly caustic enzymes into the belly, triggering a massive whole-body inflammatory response. Ranson's criteria is a classic, deeply validated scoring system to predict mortality. It is separated into variables measured at admission like age, a sky-high white blood cell count, and high blood glucose in variables measured at 48 hours, like falling calcium levels and massive fluid sequestration as the body third spaces fluid into the inflamed belly. A score of 3 or more indicates severe disease requiring intensive care.
In the major pearl here, do you give prophylactic antibiotics just in case that massive area of dead necrotic pancreatic tissue gets infected?
Emphatically no. This is highly tested. Unless you have proven aspirated infected necrosis, giving broad-spectrum antibiotics to sterile pancreatic necrosis does not prevent infection. It just breeds highly resistant fungal and bacterial superinfections in the dead tissue that will eventually kill the patient. You resuscitate with massive amounts of IV fluids, and you wait.
Speaking of massive fluids in the belly, let's talk about abdominal compartment syndrome. I want to challenge you to connect the dots here because this blew me away. The text explicitly warns about this happening in severe burn patients. If we connect this to the bigger picture, how does a terrible thermal burn on the skin lead to crushing, fatal pressure inside the abdomen?
It is entirely about massive fluid shifts and capillary leak. When a patient suffers a massive burn, say over 40% of their body, the systemic inflammatory response syndrome is apocalyptic. Every capillary bed in their entire body becomes wildly leaky due to the release of histamines and cytokines.
Okay.
To keep their blood pressure from bottoming out, we have to pump massive, almost unimaginable amounts of IV fluids into them. The text notes that patients receiving more than 250 milliliters per kilogram in 24 hours are at extreme risk.
Let me do the math on that. For an 80-kilogram person, 250 milliliters per kilogram is 20,000 milliliters. That's 20 liters of fluid in a single day.
Exactly. It's a staggering volume. And because all those capillaries are leaking, that fluid doesn't stay nicely inside the blood vessels. At the third spaces, it leaks out into the surrounding tissues, particularly into the highly vascular bowel wall and the peritoneal cavity of the abdomen. The intestines swell to 3 times their normal size. The abdomen fills with liters of fluid. Because the muscular abdominal wall can only stretch so much, the pressure inside the belly skyrockets.
Which physically crushes the kidneys so they instantly stop making urine, and it pushes the diaphragm up into the chest cavity so the lungs can't expand on the ventilator.
Right. It is a mechanical catastrophe born directly out of a life-saving medical resuscitation. That's why routine bladder pressure monitoring is mandatory in massive burns. You literally put a catheter in the bladder, inject some water, and measure the internal pressure of the belly. If the pressure gets dangerously high and organs start failing, the trauma surgeons have to intervene.
To relieve the pressure.
They literally slice the belly open down the middle to release the pressure, leaving the abdomen physically open with a temporary dressing until the massive swelling finally goes down days later.
The cascade of chaos indeed.
Yep.
Let's shift to hematologic disasters. The TMA differentiation. Thrombotic microangiopathies. This is one of the greatest diagnostic mysteries in the ICU. Imagine a patient rolls in, bleeding from their gums and IV sites, but simultaneously they are forming microscopic blood clots in their kidneys and brain. Their platelet count is incredibly low, and their blood smear under a microscope is full of schistocytes, which are violently sheared, fragmented halves of red blood cells. How do you tell if this nightmare is TTP or DIC?
They look nearly identical on a basic complete blood count, but the underlying biochemical mechanisms are totally different. Let's break down TTP first. In TTP, the fundamental problem is a missing or neutralized enzyme called ADMTS13.
A disintegrin and metalloproteinase with the thrombospondin type 1 motif, member 13, just rolls right off the tongue.
It does, but functionally, ADMTS13 acts like a pair of biochemical scissors. Its only job is to cut up incredibly long, sticky strings of a protein called von Willebrand factor that circulate in the blood.
Okay.
Without those scissors, these massive sticky strings float freely. Passing platelets get caught in them, forming millions of microscopic clots in the tiny capillaries of every organ. As normal red blood cells try to squeeze past these sticky webs at high speed, they literally get sliced in half, hence the schistocytes.
But the board trick, the way you solve the mystery is in the coagulation panel, right?
Yeah.
The PT and APT test.
Exactly. In TTP, the actual cascade of clotting proteins floating in the plasma is totally untouched. It's strictly a platelet and von Willebrand problem. So the PT, APTT, and fibrinogen levels are completely normal. If you see a patient with schistocytes in a completely normal coag panel, it is TTP, and you must emergently start PLAX plasma exchange to physically filter the bad antibodies out of their blood and infuse fresh plasma containing the ADMTS13 scissors they desperately need.
And what about DIC?
In DIC, usually triggered by massive sepsis or trauma, the entire clotting system is activated systemically and chaotically. The body consumes all of its platelets, A and D, all of its circulating clotting factors.
Oh.
So in DIC, the PT and APTT are massively prolonged, and the fibrinogen level is near zero because it's all been used up. The distinction completely dictates the treatment. PLEX will save a TTP patient, but it won't fix the underlying cause of DIC.
Let's talk about oncologic emergencies.
Yeah.
Tumor lysis syndrome or TLS. A patient with a massive burden of leukemia gets their first round of aggressive chemotherapy and 1 billion cancer cells explode all at once. What happens?
When those malignant cells violently rupture, they dump all of their intracellular contents directly into the bloodstream simultaneously. You get massive amounts of potassium, which will cause fatal arrhythmias, massive amounts of phosphate, which binds to the calcium in the blood and severely crashes your calcium levels, leading to seizures, and massive amounts of nucleic acids from the destroyed DNA, which the liver rapidly converts into uric acid.
And the uric acid crystallizes in the tiny tubules of the kidneys and utterly destroys them. The text highlights a crucial distinction in the antidotes for this uric acid overload, allopurinol versus resburicase.
It's entirely about timing and mechanism. Allopurinol is an enzyme inhibitor. It stops the body from synthesizing new uric acid. It's a fantastic drug for prophylaxis. You give it a few days before the chemo starts to prep the body. But it does absolutely nothing to the uric acid that has already been created and is currently floating in the blood.
So if the patient rolls in already in severe crisis with a uric acid level of 15 and failing kidneys?
Allopurinol is completely useless. You must use resburicase. Resburicase is an actual recombinant enzyme that circulates in the blood, actively hunts down the existing uric acid molecules and destroys them, converting them into a highly soluble compound called allantoin that even damaged kidneys can easily flush away into the urine.
We also briefly note spinal cord compression from metastatic cancer, usually lung, breast, or prostate cancer that is spread to the vertebrae. The immediate life-saving medical step is rapid, high-dose intravenous dexamethasone. You have to crush the severe inflammatory swelling and edema around the tumor before the delicate spinal cord is permanently crushed. The patient is paralyzed forever, followed by urgent surgical decompression or radiation.
It's a true neurosurgical emergency.
All right, our final showdown. Toxicology, the classic diagnostic duel of the hyperthermic toxidromes. Serotonin syndrome versus neuroleptic malignant syndrome, or NMS. I love this one because they look so incredibly similar on the surface. Both patients present with a 104-degree fever, racing heart, sweating, and severely altered mental status. How do we tell them apart?
You have to look at the timeline, the specific drug history, and most importantly, the physical muscle exam. Serotonin syndrome is incredibly fast. It happens in a matter of hours, usually after someone overdoses on SSRI antidepressants or mixes them with other serotonergic drugs like MAOIs or certain painkillers.
Yeah.
The hallmark physical finding using the Hunter criteria is profound neuromuscular hyperactivity. Their muscles are incredibly twitchy. They have hyperreflexia, meaning if you tap their knee with a hammer, the reflex is massively exaggerated. And they have clonus, where if you quickly push their foot back, it just beats rhythmically and violently against your hand.
And the specific antidote for serotonin syndrome.
Cyproheptadine, which is a direct serotonin receptor antagonist. And critically, you physically cool them down and give them heavy doses of benzodiazepines to relax the firing muscles. Regular fever reducers like Tylenol do absolutely nothing because the brain's thermostat isn't broken. The muscles are just generating massive amounts of heat from constantly firing.
Contrast that physical exam with NMS, neuroleptic malignant syndrome.
NMS is a rare, idiosyncratic, life-threatening reaction to dopamine-blocking drugs, typically first-generation antipsychotics like Haldol. The timeline is much slower, developing over days to weeks, and the physical exam is the exact opposite of serotonin syndrome. Instead of twitchy, hyperactive reflexes, NMS gives you lead pipe rigidity. The muscles are locked absolutely solid, you can barely bend their arms, and their reflexes are severely depressed or normal, not hyperactive.
And the antidotes here.
You need to overcome the dopamine blockade, so you give a dopamine agonist like bromocriptine, or you use dantrolene, a powerful muscle relaxant that acts directly on the calcium channels in the muscle fibers themselves to force them to uncouple and relax.
Going back to acetaminophen overdose for a second, because we touched on the liver failure, the actual biochemical mechanics of the toxicity are fascinating. It's not the Tylenol itself that kills the liver, right?
Correct. In normal doses, the liver processes Tylenol perfectly safely through sulfation and glucuronidation pathways. But in a massive, intentional overdose, those safe, normal processing pathways get completely saturated. The liver is forced to shunt the massive excess of Tylenol down an emergency secondary pathway governed by the CYP450 enzyme system. This specific pathway creates a highly toxic, highly reactive free radical byproduct called NAPQI.
But our liver has a natural defense against NAPQI, right?
Yes, a powerful antioxidant called glutathione. Glutathione quickly binds to the toxic NAPQI and neutralizes it. But in a huge overdose, you rapidly run out of glutathione stores. Once the glutathione is completely depleted, the NAPQI runs rampant, irreversibly binding to the proteins and DNA inside the liver cells, causing massive cascading necrosis.
Which brings us to the Rumac-Matthew nomogram and the antidote N-acetylcysteine.
The nomogram is a highly validated graph that plots the blood Tylenol level against the exact time since ingestion. You have to wait at least 4 hours after they swallowed the pills to draw the blood to ensure the drug is fully absorbed into the system. If their level falls above the toxicity line on the graph, you give NAC. NAC is essentially a massive influx of the raw biochemical material the liver needs to rapidly manufacture more glutathione, restoring the protective shield and neutralizing the NAPQI before the liver cells die.
Brilliant. Just brilliant physiology. And we finish the outline with quick hits on transplant medications. The critical care doctor doesn't just manage the failing organs. They have to manage the insanely toxic drugs, keeping the new transplanted organs from being rejected.
It's a delicate, terrifying balance. You have to suppress the immune system enough to save the organ, but the drugs themselves are highly toxic. Tacrolimus, a calcineurin inhibitor, is notorious for being profoundly neurotoxic and nephrotoxic. It causes severe tremors, can induce a specific type of kidney failure by clamping down the afferent arterioles, and even damages the pancreas enough to trigger new-onset diabetes.
And sirolimus.
Sirolimus acts on the mTOR pathway. It is highly known for causing profound bone marrow suppression, wiping out the patient's white blood cells, and triggering severe non-infectious pneumonitis, a massive inflammation of the lungs. The ICU doctor has to constantly juggle keeping the new organ from being rejected by the immune system while keeping the drugs from literally destroying the rest of the patient's body.
We have covered an unbelievable amount of ground today, from the intricate math of alveolar oxygen exchange to the dynamic hemodynamics of shock to the complex acid-base puzzles of the kidneys, the hormonal cascades of the endocrine system, the precise pressure-driven management of the brain, and the chaotic cascades of systemic failure. Thank you to everyone listening for sticking with us through this intense, fast-paced, and incredibly dense medical gauntlet. If anything, I hope this deep dive showed you that critical care medicine is absolutely not just memorizing algorithms or following a flowchart. It is a profound, real-time understanding of physics, chemistry, and physiology interacting at the very limits of human endurance.
This raises an important question, though, one that echoes through every single topic, every single mechanism we've discussed today. Look closely at the patterns of failure. In hypovolemic shock, the body's natural compensatory vasoconstriction eventually starves the kidneys of blood. In DKA, the body's compensatory transcellular potassium shift creates a hidden, fatal electrolyte trap. In severe brain injury, the compensatory drop in CO2 to lower pressure can cause catastrophic ischemic strokes.
The body's own defense mechanisms become the weapons that destroy it.
Exactly. Throughout this entire deep dive, we've seen how the body's own ancient compensatory mechanisms designed to save you from a tiger attack or a brief hemorrhage eventually become the very things that will kill the patient if left unchecked in the prolonged environment of an ICU. The ultimate challenge in critical care isn't just fighting the external disease, the bacteria, the trauma, the toxin. The true mastery is knowing exactly when to step in, use the math, use the pharmacology, and stop the human body from destroying itself in its desperate, blind attempt to survive.
Let that thought marinate for a while. The deeper you look into the human body, the more awe-inspiring and, frankly, the more terrifying it becomes. We started today talking about how the simple X-ray machine is useless in the ICU, how we have to navigate the completely murky waters of multi-system failure. The equations, the landmark trials, the intricate physiology we unpack today. That is the sonar we use to find our way in the dark. Thank you for joining us on this journey to the razor's edge. Until next time, keep looking deeper.